We're going on to the key people that will be speaking today. First of which is Dr. Michael Baker. And Professor Michael Baker is a public health physician, epidemiologist, and researcher in the Department of Public Health at the University of Otago. Professor Baker took a leading role in shaping New Zealand's COVID-19 pandemic response, which I think you will be quite impressed by looking at his presentation, particularly the elimination strategy. He was a member of the government's COVID-19 technical advisory group throughout the pandemic. Professor Michael Baker is also a highly active pandemic researcher and communicator during this period, authoring more than 60 peer-reviewed papers on COVID-19 and over 100 science commentaries and op-eds. And thank you, Dr. Baker, and please begin your presentation.
Thank you. Well, thanks for the introduction, Noel, and a huge thank you to Kevin for organising this webinar and the great lineup of speakers. And also, I've been a huge fan of HealthWatch throughout the pandemic. I think it's been a continuing, very helpful source of up-to-date commentary that I've used a great deal. As you've heard, I'm based at the University of Otago in Wellington, New Zealand. It's part of the medical school, which is based in Dunedin. We're a clinical school, which is part of that. And today I'm going to talk about the New Zealand experience with COVID-19 elimination. And I'll start by talking about the strategic choices we have for a pandemic response, the evidence supporting elimination, when might elimination or exclusion be justified. And there are always challenges with this kind of strategy, and it's got advantages and disadvantages that we need to be aware of. And then I'll talk about how can we build elimination into what I think we're very familiar with, pandemic preparedness or prevention, preparedness and response. So my main message from this, I'll say right up front, is that I think strategy is absolutely critical. And we saw around the world the benefits of having a clear strategic response to the pandemic, and I think it applies to all emerging threats. And if you don't have that clarity, I think there can be a lot of confusion, a lack of coordinated responses. So this is one of those ideas that I think has been with human populations for thousands of years, the idea that strategy is important. So when we think of how we approach infectious disease control measures, there's a very familiar typology that's been around for over 30 years. And this is that quite often we don't do anything in particular for many mild infections. But in general, if an infection is reasonably impactful, we have control measures. They may be to reduce transmission, and also obviously, as we've heard today, you also have to look at effective treatments. And in general, we are using what you could call a suppression approach. I don't think generally healthcare workers would think we're suppressing something, but in reality, this is the approach we take to an ancient pandemic, if you like, tuberculosis, a more recent pandemic, HIV/AIDS, that we are trying to keep case numbers as low as possible. Now, there is another strand to control, and that, of course, is mitigation. And this is quite an unusual approach in general because it's really confined to pandemics, and that's where the system may be overwhelmed by a wave of infection. And we know from past influenza pandemics that they can sweep through a population in just a few weeks and be absolutely devastating, as we saw in 1918. So this really became the template for pandemic responses, and that is to do as much as you could to flatten the curve. But more recently, we do have elimination, and increasingly particularly with antibiotics and other interventions and public health and social measures, we've got a growing list of diseases where elimination is the stated approach. And sometimes we can get to eradication. Obviously, this is the global reduction to zero. So elimination is reducing transmission to zero for a defined geographic area and period. And to do this globally requires obviously a huge collective global effort, which we've only seen for very few diseases. So if we look at this list here, we've eradicated some diseases. We have eradication underway for other diseases. And we have regional elimination approaches. And I guess the best example is measles. But there's a long list of diseases where elimination is the current preferred approach. And we may see, hopefully, the decade of elimination where a number of global infectious diseases start to be removed, at least at a regional level. So The New Zealand experience with COVID-19, I think for a lot of us, it began in January 2020. We had very high quality papers starting to come out from China and Hong Kong, confirming this was going to be a global pandemic. And in many ways, the characteristics of how the virus was behaving were already very well established. We knew its reproduction number. We had some idea of the infection fatality risk. So we could see this was a pandemic that, if we couldn't control it, was going to sweep across the globe and would kill tens of millions of people. That was obviously very depressing. But then at the end of February 2020, there was a remarkable paper or report published, and this was a report of the Joint Commission to China from the World Health Organization that had global scientists and Chinese scientists, and they confirmed that China had actually contained, or to use another term, eliminated the transmission of COVID-19. And this was really a world first to have a respiratory pandemic stopped in full flight. And the epidemic curves were declining based on very intense control measures. So that convinced me, that was a proof of concept, that elimination was the way to go. And I became a big advocate for that approach in New Zealand. But by March 2020, SARS-CoV-2 was circulating in New Zealand. So at that point, I realized that we needed a rapid, vigorous response to eliminate it at that stage. So New Zealand effectively adopted an elimination approach on the 23rd of March 2020. And the government didn't use that approach, that term, but it introduced a rapid stay-at-home order. It had already shut borders to entry by non-New Zealanders and then by returning New Zealanders as well. So this involved a massive, proactive, anticipatory response, because we had only 100 cases in the country at the time, probably more than that, but 100 reported cases and no deaths. So we'd been writing, and then we published, I think, what is probably the world's first published COVID-19 elimination strategy. So the strategy has a small number of very obvious approaches or interventions, and that is, you have to exclude cases, keep it out at the border, and you have to have case and outbreak management. So that is, if it's already circulating, you have to basically stamp it out. So testing, contact tracing, isolation, quarantine, very familiar methods. And then you have to have this as a backup if there are more incursions. And then in addition, you have to start preparing for what may be widespread community transmission in the future. And we've already heard presentations about the kind of interventions here that are needed. And of course, vaccination was hoped for, but definitely not a certainty at this stage. And you also need a social safety net, given that these sort of interventions are very disruptive for and very unequal in terms of their impacts. So we were very pleased to produce the first published report of the elimination of COVID-19 in New Zealand, and this is a paper you can access that describes the phased introduction of border measures, community transmission controls, and case-based measures and other approaches. So as we know, throughout the pandemic, the virus doesn't stand still. It was evolving before our eyes with natural selection, gradually resulting in variants that were more transmissible and had shorter incubation periods, so were going to be harder to control. So one thing we were aware of is that your response strategy needs to change as the virus is evolving and also as you're introducing other approaches. So we had elimination through for almost 2 complete years. With the Delta variant, we switched to suppression. We still had low case numbers. And then when Omicron arrived, it became impossible to contain it. We switched to mitigation, which is still our ongoing strategy. And then, like the rest of the world, we had waves of Omicron and its subvariants that are continuing to the present day. So firstly, the major benefit of elimination is buying time. This is showing the fact that we gave us time to achieve high vaccine coverage before we had widespread infection. The other thing that was going on, of course, is that our medical workers were learning about how to manage seriously ill people much better. The fact that you could treat them with high-dose dexamethasone and oxygen treatment. Most people didn't need to be ventilated. So there were many reasons why time is on your side with an emerging new pathogen. So this is showing one of the major measures of the impact of a pandemic, and I think it's still one of the most robust. So this is showing cumulative excess mortality over time. And what it's showing is the kind of trajectory of countries like the US and the UK that I think in general had fairly uncoordinated, non-strategic responses. I don't want to be harsh, but I think that would be how we could consider them. And we saw a cumulative mortality of getting up to over 0.3% of the population died over that period. And in countries pursuing elimination, they, for the first 2 years of the pandemic, kept their cumulative mortality very low. And even after 3 years, New Zealand still had net zero cumulative mortality. And in some way, this is mainly because even though mortality started to rise once Omicron was circulating, the loss of mortality from other respiratory infections produced this net lower mortality over that period. So one of the criticisms of elimination is that it maybe reduced freedoms for people, but that's not the case. With elimination, we didn't like the term lockdowns, but we did use them to say, but for a different reason. It wasn't to have continuous lockdowns, it was just to eliminate the virus. And then you went back to life as usual for long periods. And overall, that's the time dimension. But if you look at average levels of stringency, this is using the Oxford Stringency Index. New Zealand had low stringency of controls for 2 years on average, compared with other countries like Sweden, UK, and the US. Not presenting much data on the economic impacts, but overall, New Zealand came through this period well from an economic point of view, because of course the import-export economy was unaffected by these measures. You're only controlling the entry of potentially infected people. It doesn't alter the way goods move across borders at all. So what's the evidence showing? Well, if now with the additional data looking back over this period, and this is a comparison of looking at 6 island countries in the OECD. So the commonality is all these countries have the ability or the natural advantage of being surrounded by water. They're all high-income countries. And this is looking at 6 of them. And this is showing in terms of a ranking of the proactivity of their response and excess mortality. There's a strong inverse relationship. So the more proactive approaches were based on the intensity of controls, and the timing was associated with much lower excess mortality. In terms of the economic ranking, there's not such a strong positive relationship, but it was certainly showed that, again, high proactivity was generally associated with reasonable macroeconomic ranking. And again, stringency, proactive approaches were associated with a lower median stringency of control measures. So using these high-level indicators, they're very supportive of this proactive elimination response. So this is a very dense slide, and this is a paper that's still in preprint, but will be hopefully published shortly. And this is now looking at all of the countries that are covered by the Global Burden of Disease study, and that has excess mortality data for this period. And it's showing that countries with explicit elimination approaches or jurisdictions had very low excess mortality over this period, essentially no excess mortality compared with the rest of the world. Now, these are a subset of countries that did take proactive approaches. Many Pacific islands, for instance, also did elimination or exclusion. Interestingly, it showed that a longer duration of border control for island countries was also associated with lower excess mortality. And there was no significant difference in terms of GDP growth, suggesting that stringent controls don't significantly harm economies relative to other approaches. So this is one of the objections sometimes raised. So this is to say that we don't want to ignore other countries that also appeared to pursue elimination early on in the pandemic, but didn't describe that in quite that way. And there are a number of countries like that that are shown here, that they largely excluded this virus for 12, 18 months, almost 2 years, and they again sustained low cumulative excess mortality. And these are lower income countries with long, complex land borders. So this is a restatement of that strategy. We published this typology of response strategies in the BMJ at the end of 2020. And one of the refinements here is we split elimination into exclusion. And exclusion is achieving the same thing, but it's a much more proactive approach where you rapidly recognize that you've got an emerging threat on the horizon and you shut your borders and just allow people in by quarantine. And it has huge logistic and other advantages. So, what situations might exclusion or elimination be justified? Well, this is one of several ways of looking at emerging pandemic threats. This is going from low to high case fatality, low to high transmissibility. So these are the kind of high level categories of threats we need to be very concerned about. Of course, non-seasonal influenza, including avian influenza, is the most, if you like, predictable pandemic threat. We just using smallpox as a disease that is still exists in a very small number of laboratories and can be potentially recreated now with modern techniques. But emerging disease X, this has been the main source of course, new pandemic threats, spillover events from animal reservoirs. But now we've got a new category, novel synthetic disease X, such as bioweapons and laboratory leaks. And so we just have to recognize now that there are a large number of potential sources for these diseases. And I think this is a threat we have to be very concerned about. So we have now some modelling which I think provides an estimate for the likelihood of a COVID-19 magnitude pandemic in the future. And this modelling suggests more than a 2% likelihood per year. And there are, of course, multiple ways of looking at new pandemic threats. In general, we have to look at severity and controllability as the two critical dimensions for assessing these emerging problems. So this is looking at this in a very crude way. This is saying, under what circumstances might exclusion be justified? These are, if you knew, you could see there was an emerging novel threat globally, and I'm using one measure, the infection fatality risk. So this is saying if perhaps 50% of the population got infected, what proportion of them would be expected to die from that infection? And we can see in many ways the benchmark is the 1918 influenza pandemic, where this was around 1 to 2%, but it was sometimes much higher in some populations. And most people would say this is totally unacceptable. So I think that's still a benchmark. Below that, you have SARS-CoV-2, which had an IFR in this range during its first year. And I think countries that pursued elimination, it was regarded as an acceptable approach and highly supported, certainly in New Zealand. And now we're having inquiries which show that that has a lot of public support, and it certainly did at the time. Obviously, there are far more dangerous threats with much higher IFRs. And of course, most emerging ID threats, we'd never think of an exclusion strategy. And that's most of the public health emergencies of international concern. And we know now there's a growing list of these. You may have an elimination approach, but you would certainly, I mean, a number of these infections, we certainly don't tolerate transmission. It's certainly in high income countries, and ideally, we'd want to eliminate them if we could, but we're not going to contemplate an exclusion approach. So, what are the challenges of elimination? There is a long list, of course, and some of them we imported, make influenza great again. A very odd sign, but this was, I think, an event that jolted New Zealanders. This was a protest at Parliament, just as we were finishing the elimination period. But there are huge logistic demands to establish and sustain this kind of response, to maintain border controls. You have to use public health and social measures to manage outbreaks. And one of the great challenges is the exit strategy, shifting or transitioning from elimination to suppression and then mitigation. Equity is always a key goal, and maintaining public trust and social license for these measures. But many of these challenges also apply with other pandemic response options. So this is showing one of the most dramatic graphs we saw during the pandemic period. This is showing that pre-pandemic, there were about 20,000 people flying into New Zealand every day. That dropped to about 500 and stayed there for almost 2 years. Apart from, we did have a green zone with Australia, which I think worked well, but it was a bit challenging. But this again is a way that we can make elimination and exclusion much more effective by having green zones of linked countries, and then coming out of the elimination back to suppression and then mitigation. So one of the challenges of elimination is that you have to implement these measures very rapidly. And This is showing simulations of what would have happened if New Zealand had delayed border closures and also the stringent control measures that were introduced early on, the lockdown or stay-at-home order. And really, you can rapidly lose control of a pandemic wave. And so I think this has been seen in some other countries or parts of Australia where they delayed, in Victoria, for instance, an effective elimination approach for just a short period. So advantages of elimination, I mean, I've been running through these, so again, sorry, a long list there, but if becomes a global strategy that can support elimination at source and prevent a pandemic, so that's the ideal. Delaying transmission, as I've said, gives time for interventions to reduce harm, reduces deaths, disabilities, protects the healthcare system. As I've shown, it reduces restrictions and causes less economic disruption. People are still going and eating out and going to big stadium events. And this was the experience in New Zealand for the best part of 2 years. And the other thing is that it can prevent a very diverse range of pandemic scenarios. It's not pathogen specific. And that can strengthen, I think, health security. And again, I mentioned about a globally and regionally coordinated approach. If the World Health Organization embraced this as a organizing strategy, I think it would be far more effective at a global level and far less costly. And also, I think hopefully, as part of the IHR and pandemic treaty, these all encourage a far more equitable global response by investing in low and middle income countries and their capabilities. Again, there are disadvantages, and obviously, you have to deliver the strategy well because it does have potential negative effects. If it's inappropriately or poorly delivered, you can see it could draw resources into elimination that aren't going to give a return. And there are economic and social costs, and it can threaten equity. It can erode social cohesion. So you need to really engage the public in this. And as we saw in New Zealand, a focus for disinformation. And there's always unintended consequences from even the most effective interventions. And this is the main objection from the World Health Organization about the concern that border restrictions can really disadvantage low and middle income countries. So if you're going to build this into your pandemic plan, we know prevention and preparedness and response. It is just about these three broad approaches, and we need to be doing this in this. We're in a transition phase. We still have arguably the COVID-19 pandemic. It's still coming in waves, but we are moving gradually into an inter-pandemic period. And even in this phase, we need to be vigorously planning for the next pandemic. And as I said, strategy is absolutely critical. Obviously, we need infrastructure, and the best way to develop this is to continually do it, not wait for a pandemic. This is just core business, and this engagement with the public and why we do all of these things. One of our recommendations coming out of the New Zealand work was a paper we published in the Lancet advocating, this was trying to feed into the review of the international health regulations, which are a wonderful piece of global health law. And our proposal was that when the World Health Organization assigns this category of being a public health emergency of international concern, that it also assigns a strategic response. And this is where we'd say elimination leading to eradication could be optimal in some instances, but in others you'd say, well, in most instances, control would be the preferred approach. So something I haven't said much about is, of course, is the other part of this formula, that's the pandemic prevention. That's obviously reducing spillover infections, improving the quality of laboratory containment. And this again needs global effort with agencies, law, and again, infrastructure and laboratory management and so on. We're working very hard on communication. For us, as a result of the pandemic response, we've been funded now to set up a public health communications centre. We're putting out a lot of material, including on pandemic preparedness. If any of you are interested, you're very welcome to log on and sign on to get information from New Zealand about our thinking on pandemic issues. And in conclusion, an effective pandemic response ultimately critically depends on an evidence-informed strategy And this, in my observation, it's this fusion of effective science and good political leadership. These are, as we know, as looking globally, these are absolutely effective. These are a wonderful tool if they can work together. And finally, the dream result, an effective pandemic response, a public health triumph, nothing happened. So I just want to again acknowledge a huge, just a small sample of my close colleagues who I've worked with during the pandemic response. Thank you.
Thank you, Dr. Baker. Appreciate your presentation. I have just one question from the beginning of your presentation. We have about 1 minute. It looked like the excess mortality was actually negative, which means that you actually had fewer deaths than expected during the early part of the COVID pandemic. Was that right?
Right. And basically, like certainly all temperate countries have excess winter mortality driven by respiratory infections, particularly influenza. But we had 2 years of no influenza, so we effectively saved about 1,500 lives every winter. And it could be a form of mortality displacement, but it did push us into the negative range for those 2 years.
Right.
And it was really quite a big reminder that a lot of these infections that circulate are not inevitable. These are modifiable or deaths that can be delayed, and people can enjoy their older years in particular in greater safety if we can manage these infectious risks more effectively.
Yeah, we had that here in the US as well. I believe the
Mm.
influenza deaths went down, but unfortunately, we had hundreds of thousands of COVID deaths and
Yeah,
increased car crash mortality, things like that. Okay,
yeah.
thank you again, Dr. Baker. We're going to go on to the next speaker.